Welcome PGY1 medical officers and residents to this 12-minute masterclass on surviving renal emergencies. I'm Dr. CJ Renal. Today, we're going beyond the basic textbooks to look at real-world clinical decision-making, examining the physiological principles that govern our electrolyte management and the critical safety pearls you need at the bedside. It's about being safe and systematic. Nephrology patients are often the most complex in the hospital system, with high comorbidities and medication loads. Our scope today is comprehensive. Potassium imbalances, hyponatremia, AKI, and today we'll do a deep dive into a mixed metabolic acidosis case. We'll start with the most immediate of all emergencies, hyperkalemia. Case 1. A 63-year-old male with ESRD and a previous colectomy presents with lethargy and a potassium of 7.3. His lungs are clear and his chest X-ray is normal. This clinical stability despite a very high potassium is your first major clue. We must verify this level before jumping to aggressive treatment. Is this potassium real? Before aggressive shifting, rule out lab errors like lysis or the EDTA effect. Always take a good dietary history. Increased intake from bananas, root vegetables, or Nioni juice often explains acute rises. We treat the patient, not just the number, so verify suspicions with a fresh sample. Regarding potassium clearance, resins like resonium do not work if the patient has no colon. In ESRD, the colon is actually the main seat of potassium excretion, handling the vast majority of the load when the kidneys fail. Without a functioning colon, resins are ineffective for emergency or even maintenance clearance, a vital safety point. While we use calcium for cardiac stabilization, you should avoid IV calcium if the ECG is normal. Furthermore, it is extremely dangerous in cases of digoxin or tetrodotoxin toxicity. This stone heart phenomenon was demonstrated in animal studies in the 1930s, though it's becoming increasingly less recognized in modern human practice. Still, verify the drug history before giving IV calcium gluconate. Shifting potassium with insulin and glucose is standard, but adjust based on the patient's count. Give 50% glucose alone if they are hypoglycemic, or insulin alone if hyperglycemic. Most medical errors here revolve around inaccurate kit usage. Remember, shifting is only a bridge. We need a definitive exit strategy for the potassium. For life-threatening hyperkalemia, hemodialysis is the definitive therapy and should be performed within 2 hours, right as the insulin effect on K translocation begins to wear off. CRRT does not clear potassium fast enough and is discouraged as first line. Even PD patients with severe hypokalemia may need to be converted temporarily to HD for faster clearance. Now, Case 2, a 71-year-old with weakness and a potassium of 2.3. He has several comorbidities and shows a metabolic alkalosis with high bicarbonate. This is a classic example of a diuretic-induced contraction alkalosis, and we must identify the exact source of his potassium and fluid loss. In contraction alkalosis, low urine chloride is your absolute best marker of volume status, proving far superior to urine sodium. Additionally, you can differentiate renal potassium loss from colonic loss via a urine potassium to creatinine ratio greater than 2.5. We use these markers to assess the patient's volume status and the loss source. Translocational hyperkalemia is usually symptomatic due to a reversal of the resting membrane potential gradient. You can understand this profound clinical effect by applying the Nernst equation to the ratio of extracellular to intracellular potassium. It explains why rapid shifts cause such significant neurological and muscular symptoms. When replacing potassium orally, be precise about the preparation. Missed KCl is essentially 1.1 for mmol. 10 mLs gives 10 millimoles. However, SPAN-K and K-citrate have different mol contents and indications, so don't assume they are equivalent. Always check the actual K content per dose. For patients on peritoneal dialysis, potassium translocates slowly. However, in CRRT, because the dialysate lacks both potassium and phosphate, The procedure is both hypokalemia and hypophosphatemia inducing. This requires frequent 6-hourly monitoring of both potassium and phosphate during CRRT only. Adherence to strict replacement algorithms is vital. For IV replacement, avoid dextrose-containing fluids initially, as the resulting insulin release will shift K further into the cells, worsening the situation. Normal saline is your best replacement fluid in contraction alkalosis, as the chloride helps clear bicarbonate. Frequent monitoring is mandatory to prevent dangerous electrolyte swings. Case 3. A 70-year-old female with confusion and a sodium of 112. She is on Hyzar and amlodipine. This is severe hyponatremia, a profound disorder of water metabolism. The challenge here is determining the cause while managing the high risk of neurological complications that occur during correction. In this case, the managing physician decided to treat this as symptomatic hyponatremia and chose option D, 250 milliliters of 3% saline and KCl replacement. However, both KCl replacement, equivalent to replacing Na+, and volume correction with normal saline added up, triggering a catastrophic inability to move her limbs. The catastrophe is osmotic demyelination syndrome. Volume correction switched off ADH, leading to large aquaresis and sodium rebound. Monitoring urine output is vital. Large aquaresis may suggest the need for desmopressin as ODS prophylaxis. Interestingly, in ESRD, chronic high urea protects against ODS, allowing larger shifts in sodium during treatment. Is the hyponatremia even real? Pseudohyponatremia occurs when an increased non-aqueous phase from high lipids or proteins falsely lowers the sodium reading on the lab assay. Crucially, the actual serum osmolality remains normal in these cases. You must verify the osmolality before committing to any sodium correction strategy. Translocational hyponatremia is often driven by high glucose levels. For every 3.5 millimole rise in glucose, you'll see a corresponding 1 millimole drop in sodium. Always confirm the clinical approach based on volume status. SIADH is a diagnosis of exclusion. Ensure creatinine, thyroid, and cortisol are normal first. The ideal treatment strategy? Go slow. Treat hypokalemia first, as K+ replacement increases sodium. Your resuscitative fluid should be isotonic to the patient's current serum osmolality. Hence, half saline is often an excellent option to address hypotension without causing rapid sodium shifts. Frequent rechecks are absolutely mandatory. Moving to AKI. Case 4 is a 64-year-old with a femur fracture and a creatinine that has jumped to 500. A raised urea to creatinine ratio here indicates dehydration. But be aware this can be compounded by upper GI bleeding or high steroid use. We must stop all nephrotoxic medications immediately. Consider rhabdomyolysis in this trauma setting, especially if you see a discrepant result. A positive urine dipstick for blood, but very few red blood cells on FEMI. This happens because the dipstick detects myoglobin. Management requires stopping metformin, enalapril, and atorvastatin immediately to protect his remaining kidney function. AKI is staged using the rifle or Akin criteria based on creatinine rise and urine output drop. It can be community or hospital acquired. Remember that sepsis is not a direct cause of AKI unless it is severe enough to lead to significant hypotension and acute tubular necrosis. Restoring perfusion is your top goal. Investigating AKI requires a careful urinalysis. Beware of contamination from neurogenic bladders. Check the urine urea to creatinine ratio once to assess for prerenal factors. The urine dipstick and microscopy help you localize the injury by providing vital information on blood, protein, and epithelial cells. The Frusemide stress test is a powerful prognostic tool in AKI. By giving 1 to 1.5 mg of IV furosemide and measuring urine output exactly 2 hours later, you can predict AKI progression. A result of less than 200 ml of urine is a better prognosticator than creatinine or other biomarkers for identifying those likely to advance. Case 5. A 75-year-old chronic alcoholic with pancreatitis and metabolic acidosis. 2 days after starting a lorazepam infusion, he is tachypneic with a pH of 7.22. We need to identify the exact cause beyond his baseline pancreatitis. This patient has low albumin, so we must adjust the anion gap accordingly. This is a mixed high anion gap, metabolic acidosis, and respiratory acidosis. Using the rule of thumb or Winter's formula, the actual PaCO2 is higher than expected. The gap is even higher after albumin adjustment. The diagnosis is propylene glycol intoxication from the lorazepam infusion, and the clinical context also suggests an underlying metabolic alkalosis. When is it time for acute dialysis? Use the mnemonic I have PES. Intoxication, refractory hyperkalemia, acidosis, volume overload, and elevated urea over 36. Depending on stability, you'll choose between conventional HD, PIR-RT, or CRRT. Standard dialysis must be modified if hypokalemia is present to avoid dangerous cardiac arrhythmias. Regarding drugs in AKI and ESRD, be especially cautious with acyclovir, pethidine, and baclofen to avoid neurotoxicity. These are critical medications to watch. Also, preserve future AVF sites by avoiding PICC lines and venipunctures in the antecubital fossa of advanced CKD patients. Remember that AVF remains the best access for our elderly Asian population. For PD peritonitis, confirm with a dialysate culture and cell count. Antibiotics need dose adjustment on HD. Remember that IPKCl is always preferred over IV if potassium is very low in these patients. Most PD peritonitis cases do not need a CT scan unless you suspect secondary causes. Take care when managing these patients. We've covered a vast amount of material today. Remember to be an essentialist, work with resilience and empathy, and never hesitate to seek feedback from your seniors. We are available 24/7 if you are ever unsure. Good luck with your rotations and your future careers in medicine. Thank you for joining me.